So today we talk about stress, lifestyle, and silent stroke, and we're going to talk a lot about strokes in general, and particularly about how it impacts our life and how does stroke recovery also gets affected by stress. So let's begin with what we describe as stroke is a part of what we call a continuum of diseases, which is reduction in blood supply to any part of the body. So a brain attack is a stroke. A heart attack, obviously, we all know is of the heart. And if it's affecting the limbs where there's a decrease or cutoff in the blood supply, it refers to PAD or peripheral artery disease. The reason why I bring this up is it's in the same category as vascular disease, and anything we do to prevent a stroke, a heart attack, or a peripheral vascular disease tries to minimize the risk of the other one, which is to reduce the risk of all of these three. So focusing on one actually brings good effects in minimizing the risk of having another one. So let's talk about heart attacks. So heart attack or coronary artery disease is a leading cause of death in the US. And if you look very closely, stroke is actually a leading cause of disability in the US. So both of these are both vascular diseases, and both have a very high, so to speak, both morbidity and mortality. That means both survivorship and disability. So it's very important for us to focus on what is a risk for both these and what we can do to prevent or reduce the risk for both. So to give you a demographic trend, we continue to have about 800,000 strokes. These are strokes that we actually know that someone experiences. That is somebody who's had a symptom of stroke. And there are about 150,000 deaths due to stroke. That number has improved over time, and we expect it to continue to improve as we have newer and newer therapies to help, and we have more, what we call critical care sections of neurology to care for these patients. A stroke occurs every 40 seconds, and so it's very important to keep in mind that EMT paramedics are fully trained, and they are. It is, as I mentioned, a leading cause of disability, and very importantly, it is preventable. That means 70% of all strokes are first-time strokes. Let's talk about symptoms. As we all know, the classic signs of heart attack, it's like an elephant on the chest. It's a squeezing, painful experience. It causes sweatiness, it causes pressure, it causes a squeezing pain. It's extreme discomfort to a patient, but sometimes it can not be just chest pain like in women. It can be pain in the neck, the shoulder, the jaw, feeling of wooziness, dizziness, all those things. But something that is not seen with stroke is pain. And pain is very uncommon because the brain itself is a painless organ. So what do we go by? We go by symptoms that affect each part of the body that the brain controls. So for example, if it's numbness on one side of the body, either the face, arm, or leg, or weakness, or there could be trouble understanding or comprehending or trouble speaking, which has to do with the speech center or the language center of the brain. The other symptoms are sudden trouble seeing out of one or both eyes. It can be vision loss in one eye, or it could be part of the vision loss in both eyes, where people might not know what they're not able to see and might be bumping into the walls or might be bumping into other people without knowing. The other symptom is trouble with dizziness, where you have an acute onset of loss of balance or coordination, and that can also be a stroke. The other thing that I mentioned is headache can be seen with stroke in the sense that sudden severe headache is oftentimes associated with a rare type of stroke, which is due to a bleed called aneurysmal bleed. So these are not the usual headaches which we see with migraines. These are sudden. We call them thunderclap headache. Some people describe them as the worst headache of their life. And that's something to watch for. And this also gets what we call put in as a stroke alert, because any sudden severe headache is important for us to rule out what we call an aneurysmal hemorrhagic stroke. And like I said, because the brain is a painless organ, not always do strokes come with headaches, but when there is a sudden severe headache, we got to think of an aneurysmal stroke. So to simplify what we talk about as symptoms of stroke, we have all these mnemonics, often referred to as BFAST. It used to be called the FAST before, and we still use the FAST screen or the FAST ED screen that the emergency folks use. But the B and E looks at things that control your balance and your eyes, and that expands our ability to capture strokes and pay the attention right away to bring them to the emergency. So the B stands for balance, obviously, as we mentioned. The eyes for both loss of vision, double vision, or loss of vision in both eyes. And obviously face for facial droop, arm for arm leg weakness or numbness, and then speech, slurred speech, trouble speaking or trouble understanding. And then T is both time to call 911, and I've included thunderclap headache. So that's the worst headache of life or a terrible headache. You've never experienced that before. It's a first time headache. You've got to seek attention by calling 911. So what is a stroke? A stroke happens when a part of the brain loses its blood supply. It can be due to a loss of blood supply from a blockage in the artery, or it can be due to a burst blood vessel, which means there's an artery that breaks off and causes a bleeding kind of stroke. So what are the odds of having a clotting versus a bleeding stroke? So if you look at all strokes, about 85% of all strokes are clotting strokes. So among the 85%, if you look, about 2/3 of them are what we call ischemic stroke, and about a small percentage is what we call a harbinger of an ischemic stroke, also called a TIA or a mini stroke in purple. And then we have the reds, which is hemorrhagic stroke, which is about 14 to 15%. And a portion of the hemorrhagic stroke is what we call aneurysmal. That is the worst headache of the life kind of stroke, which is the hemorrhagic bleed from an aneurysm rupture. So those are all important things to keep in mind. And the reason why we have to dichotomize strokes is because the treatment varies by the type of stroke. So let's talk about the type of stroke in more detail. So as I mentioned, about 87% of all strokes are clotting strokes, which can be clot coming from an artery and going to another artery, or coming from the heart and going to another artery in the brain and cutting off the blood supply leading to that stroke. Or it could be a clot within an artery that forms over time due to a cholesterol plaque or a deposit that slowly integrates and becomes occluded or closed off to cause a stroke. People with strokes oftentimes don't have pain, like I mentioned, unless an aneurysm ruptures or bursts, like in the second picture here, which is a hemorrhagic stroke. Oftentimes, a hemorrhagic stroke can have headache as a common symptom, but oftentimes hemorrhagic stroke and clotting stroke don't differ much until we do a CAT scan to find the difference, where we can readily see the bleed on a CAT scan. So blood around the brain can cause a lot of pain because the covering of the brain is painful, whereas bleeding into the brain oftentimes may not cause pain, but can cause symptoms of weakness or the part of the brain that it actually controls. So that's the difference between the two. In terms of TIA and stroke, as we know, TIA is like a transient stroke or a transient ischemic attack, often referred to as mini stroke. A mini stroke is a short duration of a stroke symptom and pretty much has the same features of a stroke, like weakness, numbness, everything else, but it completely goes away. And typically, you should not have symptoms beyond the first 24 hours. And when you do a brain scan, we cannot see any permanent injury because the body has declotted, or some of the clot just dissolved and the blood supply came back again. Oftentimes, these are like a warning of a stroke. And what we do in stroke is we treat TIA as if it's a stroke. That means we got to get the treatment done right away. Look at the brain, look at the pictures of the arteries, make sure that there's not a stroke waiting to happen. And the risk of another stroke, a bigger stroke waiting to happen, is about 50%. So within the first 2 days, the risk is the highest. So what we do to prevent that is to not only consider medications, but also look for things like blockage in the arteries that we need to open up or we need to stent or operate on to prevent that stroke in the next 48 hours. And that is what we call a mini stroke or a TIA. So when we talk about strokes, we want to know what is the last known well time, also called LKWT here. Sorry for the short mnemonics here, but Last known well time is very important, like I mentioned, because strokes are oftentimes painless, and it is the loved ones or the bystanders who tell us when a stroke happens. Because patients themselves cannot speak or sometimes cannot know when they're weak, and oftentimes they might just have fallen off the bed or might have woken up and then noticed that they're completely weak on one side or not able to function or speak. So what we do is we go by what's called last known normal, which could be the last time somebody had seen them, or the patient may themselves know when they were last normal. So based on the last known well time, we can treat a clotting stroke within the first 24 hours. Usually within the sooner we can see them, the sooner we treat them, the better the outcome. So even though we have 24 hours of treatment time, it doesn't mean we wait 24 hours. It's very important to seek help right away, but we have these options of treating them first with the clot busting medication, which, as you know, is the alteplase or TPA, and the other is a TNK, which is also what we use at Baystate. Within the first 4.5 hours, these clot busting medications are proven to be both effective and safer compared to beyond the 4.5 hours where the risk of bleeding increases. So beyond the first 4.5 hours to 24 hours, we have another way of treating a clotting stroke, which is to actually go through a minimally invasive procedure through the groin. It's a small catheter that we take, introduce it all the way from the artery in the groin, and go through the carotid artery or the vertebral artery, which are these arteries in the neck, and then remove the clot from the brain. So this minimally invasive procedure can be done to big clots, which are visible on the scans that we do immediately after a patient comes to the hospital. And when we do this, the blood supply, we can see it coming back to life, which I'll go over in a minute. But it's very important to know that this is kind of an add-on procedure for people who have a very big clot, because before this procedure, patients with big clots would not be able to open up, and that can increase the risk of what we call complications, disability, and this is a major game changer in us being able to remove. So let's talk about an actual scenario here. So this is a patient who actually had an acute onset of right side weakness, inability to speak, and came in by calling 911, or the loved one called 911 and came to the hospital right away. And if you look at the CAT scan on the left-hand side of the picture, typically a CAT scan does not show much of anything. Sometimes we might see a bright spot on the CAT scan, like a blood clot, but oftentimes we don't see much of anything. So what we then do immediately while they're in the CAT scan is we inject dye contrast to look at their arteries and make sure they don't have a blockage that we can go after. And in this case, as you can see where the arrow points, there's a blockage in this artery going to the left brain. And this is what we call a clotting stroke, that is a large arterial stroke that not only requires us to consider clotting medication, but to go in through a minimally invasive procedure and remove the clot. If this patient were to not have the clot removed, we can expect significant disability, because this part of the brain controls not only the speech, but also the arm, the leg, and a significant portion of the brain that is affected is what we call the hemisphere of the brain, as mentioned here, or as shown here. And this portion controls the speech, the hand, the leg, and the entire body. It also is very important for higher level cognitive memory and a lot of things that the person is made of. So whenever we treat this, we not only treat the symptoms, but also we treat the person that they're going to be. And saving brain cells by removing the clot, restoring the blood, brings them to their functional independence. And that's the best thing we can do by removing that clot. So this device that we use besides the clot busting medication is called a stent retriever device. It's kind of like a stent, but actually it is not placed in the artery and left there. It actually is removed. So this stent captures the blood and lets the blood flow around it very quickly. So it's kind of like a double technology where it lets the blood pass around the clot and removes the clot effectively. And so this is oftentimes a very important tool for us, because we don't want to wait for the clot busting medication to do its job. And we cannot tell when a clot busting medication can remove the clot. So we give the clot busting medication, but at the same time, we get them straight to cath lab to get this procedure done. So in this case, as I mentioned, this particular instance, we were able to get this catheter into the left part of the brain. And as you can see, the catheter with the arrow pointed there has deployed the stent reaver, and the stent reaver is in there. It's actually capturing the clot, but you can see that the blood flow is slowly coming back. And once the clot is removed, the blood flow completely reconstitutes. That means the blood is back into the brain on the left side. So for reference, this is the left eyeball, and this is the left brain. And this is an X-ray picture as we're going through the cath lab procedure. And this is kind of like an arterial flow schematic that we do in 3 dimension. And in the cath lab, we can actually see the blood flowing through the brain as a videogram. It's like an actual video. So this particular patient did extremely well. We had to bring the patient back. In this case, the cause of the stroke was a carotid artery blockage, which is about more than 70%, as you can see. And the stent was put into the carotid artery that prevented another stroke. And the patient did very well, and we had to continue with medical therapy. And that's something I'm going to talk about in terms of addressing risk factors and medical therapy. So let's talk about the other kind of stroke. So when the patient comes in with stroke symptoms, when we do a CAT scan, we can readily tell a clotting stroke from a bleeding stroke by looking at the picture of the brain. In this case, as you can see, blood in the brain is bright, and that typically shows up right away. And so we can readily know that the treatment matters. In this case, we're going to bring them to our intercare or our ICU, keep a close eye on their blood pressure, try to control it, reverse any blood thinners we need to, and then work on the rehab. So the treatment changes. Obviously, if it's due to a leaky blood vessel, we can go in and perhaps clot it out. So we actually do the same procedure. We do the dye contrast to look at what artery ruptured, where it is, and so on and so forth. So in this particular case, this is a blood in the deep part of the brain called the thalamus, and this affects the left body. And so this patient tends to do better in that once the bleed improves over time, they tend to slowly improve as the blood goes away, which might take a few weeks, might take a month, might take 3 months. So I always tell patients, when you have a stroke, it's all about a time. There's a time frame to rehabilitation. It might not be right away, and you're going to hear more about it from Michelle on May 22nd about rehab and recovery. So let's talk about the last kind of stroke. It is included as a stroke, but it actually is a kind of a bleed outside of the brain. And this is an arterial bleed from an aneurysm. And oftentimes patients might come to us as the worst headache of their life because they never experienced it in the past. And it is like what we call a thunderclap headache, a 0 to 60 high-speed headache. It comes on very quickly, and it can be very disabling to the point that patients might just drop to the ground or might lose consciousness before they regain them. Some patients might have stroke-like symptoms with weakness on one side, trouble speaking. But oftentimes we can see this readily on the CAT scan, where we can see blood around the brain on the CAT scan, and we can actually go in and either coil or clip. And these are the 2 procedures we do. We kind of secure the aneurysm. Aneurysmal hemorrhages have the highest complication rate because of the bleed that's already dissipated around the brain. They are not only at risk of further bleeding into the brain, but also other neurological complications like strokes, cognitive problems like memory, headaches, rebleeding, and also what we call as hydrocephalus or fluid buildup in the brain. And sometimes they can have seizures. And so we treat all these aspects. And as you can see, it's not all about securing the aneurysm, it's also about treating the complications, which is why we oftentimes admit patients to the intensive care unit, also called the neuro ICU. There is another way of treating aneurysm. When you cannot coil them, we put in what's called flow diverting stents. These are a special type of procedures where we try to remove the bulge by diverting the blood away from the bulge and trying to make it less bulgy, or so to speak, trying to heal the aneurysm on its own. So it's important to know that all these procedures, when we do, are done usually with catheter angiogram and interventional neurosurgery. And it is important to know that most patients may not know they have an aneurysm. So the next topic is, who do we screen? And oftentimes we might pause to say that we screen people very often when they come in for other things, like they're having a headache, they might get screened and they might have this aneurysm. But sometimes it can be that it runs in the family. So if you know of anybody you know very close to you who has an aneurysm in the family, like in their brain, it's very important to have yourself screened, like your sisters, your brothers, your parents, your immediate cousins. Very important to have yourself screened for aneurysm, because that screening can be done with a non-invasive tool like an MRA or a CT angiogram, which is a dye contrast again, but it's non-invasive. Another possibility that people can have aneurysm and not know it is in certain conditions of the kidney, like polycystic kidney disease. These are genetic syndromes. Certain times they are due to genetic conditions like aortic aneurysm or aortic bicuspid aortic valves. These are very rare genetic syndromes, and oftentimes we educate our own colleagues in looking for these syndromes to look at the brain aneurysms. So it's very important to know that there are certain things that we look for actively in the community as we screen them. Let's talk about the topic that we are about to speak is silent strokes. Not that we have spoken a lot about actual strokes with symptoms. We are going to spend some time on silent strokes. Silent strokes, by definition, are strokes where a patient or a person does not know they've had a stroke. So how they find out is you get an MRI or a CAT scan, your primary care or your family doctor orders a CAT scan, say because you're having multiple falls or you're having headaches or memory loss, and they're trying to look for things. And sometimes even for tremors, they might be looking for things like Parkinson's, tremors, and they're trying to do an MRI. And sometimes the read comes back as a small stroke is seen, indeterminate time frame. We don't know when it happened. And oftentimes you cannot tell when it happened on an MRI, but MRIs tend to be more sensitive in picking up these kind of strokes. And our radiologists are learning more and more to call them silent strokes because we're seeing more and more of these. And our MRI technology is improving, obviously. And our ability to identify this is improving. So we're seeing an increased incidence of these, what we call silent strokes when somebody gets an MRI. Silent strokes are oftentimes what we call as small artery strokes. They're less than 1 centimeter or 1.5 centimeter. And oftentimes we see them as like a white spot on MRI or a small hole on a CAT scan. And what we then do is we kind of look at what could have caused the stroke, but we can go back and ask the patient, have you had any symptoms? And oftentimes they may not recall having any symptoms. Oftentimes they may say, I may have felt weak on one side. I might have had dizziness. I might have felt numb. I kind of just shook it away and let it kind of subside on its own. Or people may not even have knowledge of it. Sometimes it can be that they're falling often and they're having the silent stroke accumulation, which has led to their fall and not the other way around. So that can also be another, cause or impact of having the small stroke. So let's see how the MRI looks like. This is kind of an actual picture of a cross section of the brain. And on the left diagram, you can see a small hole in the brain. And this is a normal ventricle, but you can see a small hole where the arrow is, the dark spot. And that's typically what we see on MRI. These are extremely small areas in the brain that, extremely small stroke in the brain in an area of the brain that might be deep in the brain. And this is where we oftentimes see these strokes. These are what we call deep penetrating or small arteries that go to these locations that get blocked off. And why they are silent is kind of because sometimes many of the wires in the brain are not actually supplying the hand, the leg, or the face. They're actually connecting between parts of the brain. So these patients may not have symptoms or might just feel a little foggy at times, or they might have issues with their balance or may not have any symptoms at all. And so that's the reason why patients may not have symptoms with silent strokes. The other signal abnormality we see on MRI of the brain are these white spots in the back of the brain, which correspond to aging of the brain. We call it white matter disease, or sometimes we call it what we call hardening of the artery or atherosclerotic disease. And they also predict the risk of stroke and vascular consequences. That means risk of stroke and heart attack and peripheral vascular disease in a way that we need to actually address these as well. But you can also see this with aging of the brain. So it is not always that these are mentioned to be silent strokes, but can be seen with aging. So the context is very important when we see these kind of things. Oftentimes, a radiologist says white matter disease or abnormal bright signals found in the brain, please correlate clinically. That means please talk to your patient and find out what symptoms they have and what is their age and how does it correspond to it. And this is where the interesting part comes in, which is there's a study on something called the brain aging. And there's a way to look at brain aging and predict how a person with a stroke can recover by looking at these areas of the brain. So patients who have a lot of these white spots, also called abnormal white matter disease, who tend to or who go on to have a stroke have a much more delayed recovery compared to people who don't have this kind of white disease. So it's very important for us to keep this in mind when we talk about stroke risk, not only from preventing a stroke, but also knowing that the rehab course might be a little delayed and there may be some extra effects in terms of rehabilitation. So it's a kind of what we call the pipeline to knowing how the brain functions and what the chemical age or what we call the brain age is, and not the actual stated age. So that's something that's new to the topic of neurology. Last picture on the right side talks about a bleeding stroke, and this is what we call a microhemorrhage. Microhemorrhage are picked up very nicely on MRI because MRI is a magnet, and an old blood in the brain that's deposited actually contains iron. And as you know, our blood contains iron, and iron gets deposited in the brain, and brain kind of stores that iron for a very, very long time to come. So we don't know when this happened, but we see these microhemorrhages. But a microhemorrhage on its own is not a cause of concern, but we find a lot of microhemorrhages in the brain. We got to ask the question, is the patient having symptoms, say, from high blood pressure? Is it due to Alzheimer's disease? Is it due to dementia? Or is it just that there is brain aging that's affecting the brain that's causing these microhemorrhages? That brings back to the same topic that I mentioned earlier, that these are sometimes related to brain aging. But again, when we see these kind of things, it's not a cause of serious concern that there is a risk of hemorrhagic stroke in the coming, but it is a cause for us to take action to try to prevent those kind of strokes from happening and also treat them in terms of the risk factors. So when we talk about silent strokes, it is estimated that about 8 to 11 million Americans are diagnosed with silent strokes each year. That's a lot more times than the people actually come to the emergency or seek help for strokes that are actually symptomatic. That means about 800,000 people come to the ER or seek help for symptomatic stroke, but silent strokes is 10 times or 100 times that, as you can see. And the reason why it's increasing is not because we are seeing more and more strokes in the population. It's because we are applying more and more MRIs and people are getting more and more scans of their brain, and the technology is improving. Our ability to read them, our ability to understand these things, our ability to actually look at them in very extreme detail is improving. So that's how we are kind of diagnosing them more often. Let's talk about what causes silent strokes. It's the same risks for stroke with a non-stroke or a heart attack as it is with a silent stroke. If you look at studies of people who had silent strokes, these are people who are actually prone to have strokes or already had a stroke who then go on to develop silent strokes, or they have risk factors for strokes and have age as another risk factor. So with each increasing age, there's always the risk of having the silent stroke being found in the brain. And as you can see, about 1 in 4 people over the age of 80 may have a silent stroke on MRI. So what are the common risk factors for a silent stroke? Like I mentioned, is also seen with stroke, is high blood pressure being the most common, diabetes and smoking. These are the most common risk factors for both stroke and silent stroke. So this is a call for action for your primary care when they see the word silent stroke on the brain, MRI, look at these numbers. Talk to your family doctor, ask them what your numbers are doing, and we're going to address all of these in a minute. But silent strokes, just like symptomatic strokes, can have the same risk factors as strokes. So can have the same risk for future strokes because they are similar to strokes in terms of the risk factors. So Why do we care about the silent strokes? Is because we want to address another thing that happens with silent strokes called vascular dementia. The more the silent strokes, the more the number of these silent strokes, the more likely they are likely to have what we call cognitive decline or memory loss or difficulty with participating in activity due to this condition called vascular dementia or vascular cognitive impairment, wherein patients might have difficulty functioning, memory, being able to participate in tasks that correspond to high levels. So something that needs to be kept in mind, and which is why we talk about silent strokes more often in terms of addressing the risk factors, not only to prevent future strokes, but also to prevent vascular dementia. This I'm just folks need to stretch a little bit. Please do so. I had to turn off my air conditioning, made a lot of noise back there in the background. Let's talk about silent strokes and what we should do. So it's important to know your numbers. That means talk to your primary care doctor and know what your risk factors are. You might get a referral to neurology or a vascular specialist or a cardiologist to look at the arteries. Sometimes we do what's called a carotid artery scan, or we do a CT angiogram, we look at the neck arteries. Sometimes we do a heart ultrasound to see if there's any damage to the heart, because arterial problems are not just of the brain. The arteries flow to the heart, to the legs, so we kind of look for those things. And we might also look for additional vascular diseases. Like I said, scan the legs, look at the pictures of the arteries of the brain, the heart, the abdomen sometimes, all those things. So it's very important to treat risk factors when you find these silent strokes, because what you're treating when you're treating a risk factor is you're preventing future heart attack, a future stroke, and also future vascular dementia, as I mentioned, because that's something that we see with silent strokes. So what puts people at risk for stroke or a silent stroke? Things that we cannot change include age. Obviously, we all age, and that's something we can't reverse. Family history, we cannot reverse, and that's very important to note that premature atherosclerosis or hardening of the artery with stroke or heart attack, especially below the age of 50, is very important to note and discuss with your primary care doctor. The other thing is gender. As you know, stroke recovery sometimes and stroke severity sometimes can be more often seen in women more than men, and race is another important factor, but obviously race is a very complex component because many of us think of it as being a particular ethnicity or background, but oftentimes it may just be hereditary, coming from a particular location, or it may be genetic more often. And then of stroke or heart attack puts you at risk of stroke and heart attack, especially because your risk factors are not controlled. So it's very important to look at those. So what can we do to control our risk factors? The things that can be changed include everything that I mentioned earlier: high blood pressure, smoking, diabetes, lifestyle, which I'll talk about in a minute, physical activity or inactivity, and obviously alcohol, drugs, drugs that are illicit, vaping, energy drinks. All those things can also put people at risk for strokes, and I'll talk about that in a minute. High cholesterol or improper cholesterol, that means high LDL or lousy cholesterol, low HDL or good cholesterol, all those can play a big role in hardening of the arteries. And lastly, the topic that we're going to talk about is stress, and that's another important factor. Conditions that actually cause a stroke and increase the risk of stroke include a condition of the heart called atrial fibrillation. This is a particular heart rhythm that may go unnoticed and can happen to anybody with a normal heart. It means you don't need to have a heart problem to have this condition. This condition increases with age and can be a risk for silent strokes. That means people with silent strokes can have atrial fibrillation as a cause of silent stroke, or can have strokes to the brain due to atrial fibrillation. So how do we find out if people have AFib? Is to do a cardiac monitoring. And sometimes we do what's called a cardiac Holter monitor or an implantable loop monitor. That's something we talk about very often. The other thing that can actually cause a stroke is carotid artery, where the clot breaks off from the heart, from the carotid arteries, and goes to the brain. The third important thing that can actually increase the risk of stroke by increasing the other things that cause a stroke, like high blood pressure, atrial fibrillation, heart failure, is also called sleep apnea. This actually is more common in men than women, and that's where even snoring in men should be taken seriously, but not all people who snore have sleep apnea. But most men who snore might have sleep apnea, especially if they already have stroke risk factors like high blood pressure, they've had a previous heart attack, or they're prone to having heart failure or heart irregularity like atrial fibrillation. So something we need to watch for by doing a sleep study. And nowadays, it's very good to do a sleep study because it's very easy to do one at home and you don't need to come to the hospital to get one done. That's another important thing to keep in mind. Let's talk about physical activity. So it's very important to keep moving. Moving is a very good thing because moving not only improves blood circulation, it also improves physical fitness, it improves the circulation, it improves the health of the arteries. And when I talk about moving, it's moderate physical activity, and it doesn't mean you have to like lift weights or do the jumbo things like do heavy exercises. It can be brisk walking or jogging or running with your dog, even if you don't have one. So those are all things that the American Heart Association wants you to do for about 30 minutes, at least 5 times a week. This is one thing that I cannot beat on more, a very important thing that we all need to do. The other thing is nutrition. So oftentimes, we don't care much about because we don't know what we're eating makes a big component of how or who we are. And what I want to talk about first before I go into diet is what we don't want to consume. And what we don't want to consume is energy drinks. So I'm not talking of coffee or tea. I'm talking of all those drinks that are sold and marketed. And most people drink energy drinks. And when they drink a lot of those, especially they stay up in the night and drink a lot of those, they go into what's called a cardiac arrhythmia, which then predisposes one to a stroke. And previously I mentioned something about AFib. That can actually be a silent cause of stroke. That means the irregular heartbeat can cause the blood to not circulate well in the heart, and that clot can go to the brain. Another thing that's important to keep in mind is avoiding decongestants. We've had people come in with strokes due to multiple over-the-counter cough and cold medicines. So we want to keep that in moderation. Try to avoid as much as you can, especially people who are over the age of 50 or 60 or have high blood pressure, cholesterol, diabetes. You don't want to use decongestants as much because these can actually cause the artery to go into spasm, and that can increase the risk of stroke. Just like smoking, vaping causes increased risk of stroke, especially in young people. So quitting smoking is very, very important, but going from smoking to vaping is not going to help us in the long run because that's going from one part of a trouble to another part. It's like, going from a rock and a hard place. So vaping is very important to not use as much as possible. And there's been a lot of reports on vaping and stroke risk. And in women, especially in people who are perimenopausal taking estrogen supplements, the risk of stroke goes up 50-fold, especially with clotting, if they use a lot of estrogen supplements and they have a history of migraine with aura and they're smoking. So that's something you don't want to consume and avoid as much as possible. So these are all the things what we want to talk about, we want to avoid very much. But what do we want to take actually is the next topic. And this is what we refer to as a Mediterranean diet. And this is recommended by the American Heart Association. The key to success with any diet is reducing what we call saturated fat, reducing the sodium, and that's highlighted in red here. The lower the sodium, the better it is for the body. So the American Heart Association comes up with this recommendation to keep the sodium below 1500 milligrams, which is, a teaspoon or less a day. A half a teaspoon or less a day. So the lower, the better. High fiber in the diet, as we all know, is very important. And then fatty fish, which is a part of the Mediterranean diet, improves what we call the omega or the good cholesterol. And omega-3 in fatty fish is better than the supplements, is what we found in many of the studies. So people taking multivitamin supplements, we don't have objections, but it may not work as well as actually consuming the whole foods of fruits, vegetables, and fatty fish, which actually make a big difference in the arteries and the health of the arteries. And what we want to avoid is reducing the processed meats, not only because they have high cholesterol, but also because they have a lot of sodium in them. So salt intake is a big topic here when it comes to lifestyle modification. America consumes a lot of salt in their diet without knowing it. About 70% of the packaged diet has a lot of salt, more than what the salt shaker does. So keeping the salt shaker away is a good idea, but also look at your labels. If you have a lot of packaged prepared foods, it's going to have to go away because that has a lot of salt in it. The average American population consumes 2.5 to 3 times the amount of salt that the American Heart Association recommends. That's about 3,500 milligrams, and the recommended amount is about 1,500. And for a reference, a teaspoon of salt is about 2,300 milligrams. So watch what you're eating by looking at the package labeling. And most of the recent, if you go to the grocery store or the marketplace, you will see low sodium options. You will see reduced salt soups, reduced salt packaged foods, which is a great thing, but still needs to look into it because they still have salt and they can all add up. So look at how much salt you're putting into your body on a daily basis, kind of make a meal plan and come up with a plan. Now, smoking is another important thing in lifestyle modification. Quitting smoking greatly helps cut down, not only in the short term by improving your circulation, but also in the long term by reducing risk of silent strokes, heart attacks, and also vascular dementia. So quitting smoking is very important. Not only to reduce the risk of stroke, but also the long-term side effects and consequences, especially with cancer, as we all know, lung cancer and so on. So what do we do to quit smoking? Sometimes we might talk to our doctor, talk about nicotine replacement, like nicotine patch, medications that are out there. There's a lot of medications out there, but some people, and I hear this a lot, I want to quit smoking on my own, which is a good idea. And how often do you do that? You might do it 3 times. You might do it as often as 5 times before you finally quit. So never give up just because you're not able to quit once. Keep trying. So if you're a smoker, keep trying to quit smoking, and that's the best thing to do. Blood pressure is a very important topic, and like I mentioned, it's highly linked to the sodium intake. And so blood pressure is elevated, and the definition of blood pressure changed over the years. And now the blood pressure definition is where a number above 120 to 129 becomes elevated. And that's something to be monitored. And then the stage 1 hypertension, which is an actual blood pressure, begins at over 130 to 139, or the bottom number is between 80 to 89. The bottom number is called the diastolic, the top number is called the systolic. So if you don't have a blood pressure machine at home, you can buy one or go to the pharmacy, get one checked, because it's very important to look at those numbers so that you can classify, and that's a call for action. And then stage 2 hypertension is anything above 140. So you can see over the years, we used to call anything above 140 as hypertension, but now that number has kind of come down because every time we drop a blood pressure to 120 or below, that's a lot of recovery in stroke, that's a lot of less strokes, that's a lot of less heart attacks, that's a lot of less dementia. So very important to keep that BP, the lower the better, as long as it doesn't make the low BP make you faint. So we don't want people to feeling woozy, but when you have high blood pressure above 130, say, you're on a medication, you want it to go to 120 or below, but you don't want to be woozy. As long as you get to a point where your BP is controlled and you're feeling good, you stay on that course. So that's how we want the BP to be. The lower, the better. Blood pressure is measured in millimeters of mercury. And there's a lot of machines out there you can get. Ask your doctor to prescribe one for your home. Your insurance might cover it, especially if your numbers are going up and you have trouble controlling them. Your doctor might want to know what you do on a day-to-day basis so that they can adjust your medicines. And don't be disheartened because you have high blood pressure and your BP is not going down. Very often you need 2, 3, or even 4 medicines to control your blood pressure. And so it's not uncommon to see that people need more than one medicine. And it's also not uncommon to see that people with blood pressure tend to have blood pressure running in their family. So you're not alone in that. It could be genetically predisposed. There's another thing about blood pressure and diet. It's called the DASH diet. It's similar to the Mediterranean diet, but this is a diet that was studied similar to the Framingham Heart study. And it looked at low sodium, low saturated fat. And essentially what a DASH diet consists of is all the plants and vegetables and olive oil and all the what we call the monounsaturated fats rather than the animal fats. So low-fat dairy is also helpful. So you don't want to cut out the dairy completely because dairy is helpful, but you want to keep it to where it's at a minimal or moderation. Cholesterol is another important thing that we look at. Oftentimes, when people come to us with a stroke or heart attack, we start setting goals, but oftentimes it's not about goal setting, it's about working on a target so that your arteries are healthy. And cholesterol is very important for not only the circulation and the brain, but also day-to-day activities like your blood cells, the cells that your brain is made of is all cholesterol particles. So when we treat cholesterol, we are treating the arterial cholesterol, not so much the cholesterol that surrounds us in the brain. So the medications we give aim to control the plaque formation in the arteries. And sometimes we have goals for numbers, but it's more aimed to control the plaque or the buildup in the artery. Diabetes is a very important thing to control because when somebody has diabetes, the risk of stroke or heart attack goes up fourfold or fivefold. So what we then do if somebody has diabetes is we kind of tighten up the other goals, which means if your BP goal is less than 120, now your BP goal is less than 120, less than 110 maybe. Your cholesterol, we tend to be more, kind of strict about the numbers. We tend to work on weight control. We tend to work on getting you to exercise more, and we try to control the diabetes more. Thanks to the advancement in recent pharmaceutical kind of discoveries, we have a lot of medicines not only control diabetes, we call it the SGLT2 medications. Those not only control diabetes and lower the weight, they also actually improve the long-term cardiovascular disease. So talk to your doctor if you have diabetes about those new medicines because they are really game changers, not only in diabetes, but also you probably might have heard they cause weight loss. And a lot of people have been taking it for weight loss, but actually people with diabetes greatly benefit from those type of medications by preventing heart attack and stroke because they actually independently prevent this. It's not always the insulin that works for diabetes. There are alternatives to it. But if you have type 1 diabetes, then of course it's the insulin. Alcohol is another thing that's a very controversial topic. And for the sake of this discussion, I don't want to get into too much of how much a drink is for men and women. But the lower you drink, the better it is. If you are not drinking, do not start drinking. So that's the key to this message here. But if you do drink, drink in moderation and cut down as much as you can. Alcohol might have some benefit in that it has some antioxidant properties, they say, and all kinds of other things. But there have been increased reports of cancers from alcohol. So you want to reduce that. There's always a risk of blood pressure going up with alcohol. So try to reduce or use less of alcohol as much as possible in moderation. Obviously, the effects of alcohol on the liver has been going up. We are seeing more and more liver disease. So trying to cut down on alcohol is a very important thing these days. And the most important thing that we want to talk about and is least spoken about when you see a doctor is because we don't actually get training in medical school about how stress works. We know that stress causes a lot of other things down the road, like stress affects how our risk factors affect us. Stress affects a lot of things down the stream in terms of our sleep, our ability to think, our functioning. But how does it actually work is that it leads to other things that then cause the risks to go up, like high blood pressure, diabetes. And it's kind of a cascade of events. So when we talk about stress, it can be small things like, oh, I cannot get to this in time. I got to rush there. I got to do this. So kind of like you want to time yourself and don't sweat with the small stuff. These are the small things that matter the most. What we stress about small things actually affect the long-term health of our arteries, the health of our brain, the health of our well-being. So try to manage your time, try not to squeeze too many things, and learn to relax. That means even if you're kind of busy in a day, try to look at a distance, trying to get your picture like, kind of a streaming video, or if you're looking at a distance out in the sun, or meditate. So that's very important for us to de-stress. And it applies to anybody, whether it's, a patient or even the doctor, or even, a person who is a caregiver. Like, for example, person who's taking care of a stroke or an elderly dementia, you got to give them a de-stressor because that's the most important stress is home stress. Caring for your loved one is actually more stressful. And so we got to share the importance of how we are treating stress, not only for a stroke patient, but also for the caregivers. There is an indirect association between blood pressure and stress in that how we cope with stress is very important. If we cannot cope with stress, our mechanisms are to respond with stress by changing our eating patterns. We kind of binge eat. We call it stress eating, or we are kind of going into an anxiety mode all the time. We're kind of, kind of at a high alert state. Your catecholamines are going up. You're having a surge of adrenaline. That's not a good thing for the blood pressure or the blood sugar. We are also altering our diet and lifestyle. We're sleeping less. And so what happens then is if you're sleeping less, your risk of heart attack and stroke goes up because there has been an actual study on it where people who sleep less than 5 hours tend to have increased risk of stroke. On the other hand, people who sleep more also have a risk of stroke. And so what is the optimal duration of sleep is about 7 to 8 hours. So make sure you get that amount of sleep. Now, if you can't sleep, talk to your doctor about coping mechanisms. We call it sleep hygiene. We treat insomnia not just with medications, but also we're trying to look at the circumstances of what's not making you sleep. If it's stress, talk to a specialist, like a psychologist or a psychopharmacologist to help you with that. And it can be a lot of things. It can be poor sleep due to poor sleep quality. And quality is something we talk about in sleep study. What I mean by sleep quality is, are you getting enough sleep that has enough oxygenation? Are you getting enough sleep where you actually breathe properly? If you don't have the proper sleep quality, sleeping 9 hours a day is going to have a negative impact, because the more you sleep with a poor sleep quality, the more likely that you're having a stress on your brain by not giving it enough oxygen. So having a sleep study is very important to look at the sleep quality. And I cannot stress enough about how important sleep is in our lifestyle and stroke. There's an actual study about stress, and this is called the interstroke or the interheart study. And it looked at stress, and what mattered most was the home stress. The caregiver burden I mentioned earlier increased the odds of stroke by 2 times. And if you look at work stress, that's almost 3 times. Combined together, that actually increase your risk of stroke after a recent stressful life event. That life event can be something to do with your partner, it can be a loved one. So all those things cause a lot of stress. So it is very important to control your stress. So people who had locus of control, that means people who knew how to cope with their stress by telling that I'm going to change some things, or I have control over how I can do things, did better in preventing a stroke, or odds of stroke was lesser. Now remember that these are not studies where we assign people to stress and de-assign people to not having stress. We can't do that because it's very hard to do that kind of study. These are all studies that come from similar to what we do called observational studies, and then we go on and look at the differences between people who report how stressed they are versus people who don't report how stressed they are. So it's all about reporting and understanding that. A locus of control is where people can control their environment, both their home environment and a work environment. So for example, you're at work and you're stressed about something. Do you have a supervisor you can talk to and share your feelings? Do you have a partner? So try to socialize more and talk it out. That's called the locus of control. Sometimes it can be a locus of control in that you have control over some things at work. Like, for example, you can make a plan and execute it without having to go through the hoops. So that's something you have authority over. So it's called autonomy at work. Same thing at home. You can get caregiver burden at home by calling in somebody. Do you have family to help you out? You have friends you can talk to about your stress. So that is all very important. So try to socialize more and try to get out and talk to people. And if you can't do that, you can always chat on the phone or other ways to do it, which I'm going to go over in a minute. But these studies looked at how well we are able to control our focus and how well we are able to share our burden with other people. And that's called the higher locus of control. So the better our locus of control at work and home, the better it is for odds of stroke. So psychosocial stress is a very important thing. And this was recently published in the JAMA Neurology as of December. And you can welcome to look at this study. It's very important to know how you control that matters a lot. So how can you do control what refers to as a locus of control? Going into a little bit more detail is by managing your time. If you don't want to do something and you cannot do that in time, feel free to speak up to your supervisor, to your family, to your shared to your loved ones, because you cannot do it, you cannot do it. And if you don't speak up, you're kind of adding trouble not only to your loved one by being not able to do it, but also increasing your stress. When you have work or when you're doing something, try to breathe. Take a pause, take a deep breath in, like right now, if you want to do that, and then exhale and focus on your breathing. And there are other ways to doing it, like yoga, meditation. There's something called mindfulness, where you're focused on one particular thing and not on everything else. So you're kind of what's called shut down all the noise. So you're focused on one thing, like being in a nice holiday vacation or being in a spa or something very nice, and you shut down the whole thing. So that's what mindfulness is all about. But breathing exercise, yoga, and meditation have been known to lower blood pressure very quickly, and that's a very good way of treating yourself with stress. Music is a tool to help not only people who have never had a stroke and have stress, but also for people who have a stroke. So something to know about is music was recently published as a great tool. So where does music come in? It's about vocal music. That means people who sing, you know the lyrics, you learn the lyrics, you sing along with it, or you listen to it, and that improves not only with stress, but in people who have stroke and stress, because stress is a very important thing in stroke survivors. Talking about stroke that's already happened, that music can help not only improve the stress, but also improves the rewiring. Center in the brain is actually in the right brain, and very often that part of the brain is not tapped into. So listening to music, singing along with it, not only helps remap your brain, makes you more efficient, but also improves your depression and stroke recovery. So if you have a stroke or you have somebody who has a stroke, have them listen to a lot of music, try to sing with them. It not only helps the stroke person, but also the caregiver reduce their stress. So both of you get to singing, and that's a great tool. The last thing is about sleep. We spoke about sleep in a lot of detail. 7 hours is optimal, not more, not less. So make sure you get enough sleep. And moving, like I said, physical activity. If you walk, it's good. If you can jog, it's even better. But if you can't walk or jog, you can do something called a stationary bike, or you can get like a home exercise machine where you don't have to sit or bike. You can just sit in a chair and do that at home. Dancing for people who can actually have good balance is very important. Zumba or other classes that you go to actually has a very good model of stress relief or de-stressing. Last thing is about furry companions. You don't have to have a pet, but having a pet and cuddling it has been shown to improve blood pressure and a lot of other things that go into causing the stress, affecting the stroke risk or heart attack risk. So if you don't have a furry companion, don't worry about it. Get somebody else's companion and just borrow them, maybe cuddle them when you go home to their place, or walking on the street, maybe talk to the dog or a cat. Whatever you do, it's going to really help you. And stroke is very important, and I can't stress enough about not only the quantity, but also quality of sleep. If you're snoring or you're having trouble sleeping, get tested for sleep apnea. Talk to your doctor and get a home sleep study. If you have a sleep apnea or a risk of it, you might also need an in-lab study. High blood pressure, difficult to control, get a sleep study. You have irregular heartbeat, you have palpitations, get a sleep study. You already had a stroke, or you know of a loved one who has a stroke, get a sleep study. Because guess what? 1 in 3 people with a stroke tend to develop sleep apnea. And why is it important? Because stroke recovery hinges on how much oxygen you get in the night, how much sleep you get. And the worse the sleep is, the less likely you're going to do well in rehab. You're going to have more headaches, more frustration, more stress, and more depression. So in conclusion, it's never too late to take care of your risk for stroke, especially with stress, because reducing your risk of heart attack, stroke, not only reduces your risk of these events, but also vascular dementia. So talk to your doctor, write everything down, and report what's bothering to you, and also bring your family history to your doctor. And know that stress is ever present. We all have stress. Nobody has no stress. Nobody can say, I don't have stress, but know how to cope with it. And if you have somebody who has a stroke, know the warning signs. Obviously, there are the silent strokes. So talk to your doctor about memory problems, headaches, other things. They can do the appropriate scan. But if you have somebody who has an actual stroke, call 911. Time saved is brain saved. The sooner they get to these medications, the better they do with long-term prognosis. So the road to recovery is long, like I mentioned, and that will be another topic that is coming up on May 22nd about rehabilitation. But remember that rehab is very important after a stroke, and participating in music and other things play a big role in that. So with that, I'll conclude my talk, and thank you for your time.
Thank you, Dr. Padmanabhan. That was great information. I appreciate you and your time. The audience does have a couple of questions, and if you haven't typed in your questions, we invite you to do that now for Dr. Padmanabhan. The first one, can you have a stroke without having a clot? And can a stroke affect your ability to walk when there is an absence of paralysis?
So first question, clotting stroke. A stroke is always due to a clot when it's a clotting stroke. That means any stroke that's not due to a bleed is a clot. We cannot see a clot on the pictures that we take with the contrast, doesn't mean there's no clot. The clot is too small to see with the naked eye. So a clotting stroke or a stroke that's not a bleeding stroke on MRI or a CAT scan is always a clot that's formed in an artery, either due to the clot forming in the artery or it came from somewhere else. So that's the answer to the first question. A small stroke oftentimes does not show a clot in the big artery. That's because it's a small stroke. And the arteries that go to the small stroke area are a branch of a branch of a branch. It's like a tree. In my picture that I've shown you just now with the road to recovery, it's the smallest branch out there where you cannot see with the naked eye with all the scans we do. The second step to the question is about stroke recovery in terms of rehabilitation. Is that correct?
Yeah, it says, can a stroke affect your ability to walk when there is an absence of paralysis?
Oh, yeah, that's true. So you're talking about silent strokes now. So what that means is if somebody you know is falling very often and you don't have a cause, say, due to neuropathy or due to back issues, you got to have a brain scan. Is that due to a silent stroke that you're falling very often? Yes, silent strokes can make people lose their balance because remember that the brain not only connects to your body, it also talks to other parts of the brain. So to be able to talk, to be able to walk, to be able to do your functions every day, like mentate, you need not only to be able to connect your body to your brain, you need to be able to connect one part of the brain to the other. So oftentimes you don't need to have a stroke symptom and then have a fall due to a silent stroke. So this talks about silent strokes basically, and that's a very good thing. So if you have a person who's falling very often, not only do you see physical therapy for balance, but you also want to know if the fall is due to a silent stroke or accumulation of what we call hardening of the artery or atherosclerotic mechanisms. Sometimes we might be surprised to actually see a big stroke that got unnoticed or went unnoticed, which can happen in the back of the brain called the cerebellum, where people can have trouble with balance and they not know it, and they're walking around and they already have balance issues, other things, and then suddenly their balance is getting worse. So they don't know why, and it's time to look at your scan and say, is this stroke where we think it is, which is the balance center of your brain? So yes, there can be more than one things that cause falls. Not only can it be from the what we call the inner ear vestibular apparatus, from the legs, from the body, from the eyes, but also the brain. So very good question.
Yeah, thank you. Quick question, is a brain aneurysm considered a stroke?
Yes, so in the recent past few years, because of our ability to pick up on those very quickly and act on them and improve. So an aneurysm, a ruptured aneurysm, I should say, is picked up when somebody comes in. So why is it included as a stroke is because headache is not a common symptom of stroke. But we put headache as a symptom of stroke as the worst headache of your life because a brain aneurysm can cause that. A brain aneurysm, only when it ruptures, causes a headache. A brain aneurysm that is not ruptured, that's not bleed into the brain or outside the brain, may not cause any symptoms. So the only way we find out is we're doing something incidentally like an MRI and we instantly find the person has an aneurysm. So if a person finds out that they have an aneurysm, it has never ruptured, it's time to seek help to either coil it. But if you're at a certain age where you're 80 or over, you may not need to do that because it's past that certain point. But it's two ways. One is you have an aneurysm, you don't know about it. Two is you have an aneurysm that ruptured, and that's a stroke because it caused an acute headache, and that's treated as a stroke. So knowing that headache is a part of our stroke protocol, not just in Massachusetts, but throughout the country, is a very reassuring thing because aneurysms are typically not symptoms of stroke, they are just headaches. So knowing that when you come with a sudden severe headache, you're getting the stroke workup is very reassuring because that means you're being rushed to a CAT scan being treated as a stroke, but actually it's not a stroke symptom, but it is a risk of hemorrhage causing a stroke or a complication that needs immediate attention.
Yeah, no, that makes sense. Thank you. Great response. Okay. Be fast. Should you seek help if you have one of these symptoms, or are you looking for one or more?
No, we are just looking at one of them. So on the Be Fast, the balance, the eyes, the face, the arm, the speech, we are looking at only one of them because each part of the brain covers each one of those topics. So a stroke in, say, the back of the brain can affect your balance without affecting anything else, like the arm or the leg. So you can get pure balance issues without weakness. The answer to everything is sudden onset. If you have something that is going on for a long time, like you're feeling off balance, dizziness, that's not an acute stroke. But if you have something sudden that's out of control, like a balance issue, you got to come into the hospital right away. So yes, any one of those symptoms should alert a stroke. You lose vision in one eye, that's a stroke. You have double vision in either eye, that's a stroke. Very rarely you can have, like I said, this this face droop that doesn't happen to be a stroke, it's due to Bell's palsy. So that's called a stroke mimic. But if you happen to come to the hospital because you have Bell's palsy, you're not going to be slapped in the wrist. We're going to take care of that. We're going to make sure it's not a stroke before we call it a Bell's palsy. So it's better to be safe than sorry, calling it a stroke and not calling it.
Right. Thank you. This is just a quick question about one of your slides. Does the OR stand for in the cited stress odds data? The example is increased stress at home odds was 1.95 and at work it was OR 27. So the question is what the OR stands for.
I'm sorry about the short form. I should have expanded on that. When I talk to a large group of people, I always have to think that I'm talking to the doctors or the nurses. So I tend to forget that when I'm talking to the general audience. I apologize. But OR is the odds ratio. So when we do a study on people, like a large group of people, like the Framingham Heart Study, we come up with these numbers called odds. What are your odds of having a stroke for a person who smokes versus a person who doesn't smoke? What are your odds of having a stroke with that kind of stress on your scale of 1 to 5? What's your level of stress? And then we're going to see what your odds of stroke are. So we take those numbers, we multiply by the number of people, and then we divide by the people who have the event. So that's called the odds ratio. So odds, by definition, is the people who have the event versus the people who don't have the event due to a certain substrate or a confounder or something like that. So it's more mathematical equation. In simple terms, what's your odds of having something about to happen? The end outcome is called the odds ratio or the OR. So when I say 1.97, that's almost 2 times. So when I say 2 times, I want to be very accurate when I present something, so I don't want to approximate. This is directly taken from the JAMA network, so I don't tend to change the numbers. But for people who are very interested in numbers, I put it in there. But it's looking at stress, and yes, it's 2 times or up to 3 times when you have both home and work stress. So a home and work stress combined is the highest stress for stroke. Coping with both home and work stress decreases the odds of stress in the negative of 0.7. That means your odds go down and actually go in the favor of preventing it. So that's what an odds ratio is. Okay.
I know we're over time, but if you have maybe 1 or 2 questions more, this question, in terms of its ability to lead a stroke, is stress on par with the other risk factors?
Yes, I think it is because, if you look at stress, we cannot measure it very well. The biggest problem with stress is how do you quantify stress? We are still scratching the surface on it. But stress causes things down the pathway like sleep problems, eating problems, lifestyle, weight gain, cortisol excess, things that chemical imbalances, which we cannot actually measure very well, but we are starting to scratch the surface by doing all these studies. So, as you know, all the studies that have come out have been very recent. Everything that I quoted is pretty much within the last year or so. So,
Wow.
there's a lot to come. I think it is on par, but I think it's hard to measure and quantify, because high blood pressure and stress go together. Eating and stress go together, and weight gain goes along with it. So it's kind of what we call the interconnection. So yes, I think, rather than call it on par, I should say it's kind of like an integrating factor in all these other risk factors, kind of an integral. So you can't treat one risk factor without actually addressing stress, and cannot treat another risk factor without addressing stress.
Well, thank you for that answer, and thank you for the presentation. I know you've been seeing patients all day, so we'll just have to say time for this, but we do have the two other events. Thank you, Dr. Padmanabhan, and thank you, attendees, for this great event tonight. We appreciate you.